All right, hello everyone. As we let everyone in, we're running just a few minutes behind due to our last session and just having the same Zoom link. So we're getting things set up and we're trying to get one of our speakers in, which I'm not seeing her yet. Oh, there we go. The name was different. It was two Andreas. I'm sorry about that, Melanie. Let's see. We're going to spotlight y'all. Fixed. Cost. Cool. So now y'all should have all access. There we go, and we have everyone admitted. Perfect. I'll go ahead and can unmute yourself. Give me
I got it now. I can. Melanie, your name is Andrea on the screen.
I know. I think that link you gave me might have been unique to you. Let me see if I can change my name.
Okay.
Perfect. That's why I was getting confused. I was like, there are two Andreas here. And you know, I like you, Andrea, so it works out.
Nobody needs two Andreas.
All right, I'll go ahead and get us started with a little bit of introduction. So hello, everyone. Thanks for being patient with us as we get this session started. If you were in our last session, you already know who I am, but I'm Ty Aller, and I'm at Utah State University's Institute for Disability, which is our state's UCED. I'm also a part of the MHDD Center and AUCD's Mental Health Special Interest Groups leadership team. We really are excited to have you all join us for our third session of the 2021 Mental Health Summit, online discussions on the intersection of mental health and developmental disabilities. Prior to introducing our great speakers today, I wanted to just briefly go over some Zoom etiquette. We're all probably pretty used to it because the world's moved to Zoom formats, but I'll just briefly go over it. So we'll be using the chat box features today. If you have any questions or any technical difficulties, feel free to send them in there. My name is Ty Aller, and I'll be helping manage all of that. Kristen Dahl is also part of our leadership team, and she'll be here as well. You can shoot her questions. I think she has to jump off a little bit early to help run our next session, though. So feel free to send them to me if you can't see her. Currently everyone is muted, and I actually have it so you can't unmute yourselves. So if you need something, throw it in the chat, and that way it just helps us keep things running smoothly. And at the end, if there's time for Q&A, we might be able to open it up there depending on what the speakers have in store for us. The webinar is also being live captioned. So if you go down to the bottom of the Zoom controls, hit that CC button, it will pop up the closed captions. We also have ASL interpreter services that should be highlighted on your screen as well. If you can't see that, feel free to send me a message and I'll help you get that figured out as well. I'll also post that in the chat so that we're all on the same page. Other than that, I think that's our basic Zoom etiquette. So I'll go ahead and just jump right in and introduce our speakers so that we can get things on the roll. So first off, we have Melanie Hecker, who is a person with lived experience, who is a lifelong disability advocate, both personally and professionally. She holds a master's degree in public administration from the University at Albany with a concentration in policy analytic methods, a BA in public policy and management from the University at Albany, and an Associate of Science in Human Services from Hudson Valley Community College. Previously, Melanie has served as a systems advocate at Youth Power of Families Together in New York State, graduate policy intern at the New York State Council on Children and Families, policy intern at Disability Rights New York, and intern at Independent Living Center of the Hudson Valley. Independent Living Center of Hudson Valley awarded Melanie the Beacon Leadership Award in 2019, and Melanie is also a lifelong resident of Albany, New York. We also have Dr. Jennifer McLaren joining us today. She is an associate professor of psychiatry, pediatrics, and the Dartmouth Institute for Health Policy and Clinical Research at the Geisel School of Medicine at Dartmouth. She's the chief medical advisor for the Center for Start Services. She is also the medical director for the New Hampshire Bureau of Developmental Services. She received her undergraduate degree from the University of Notre Dame, her medical degree from the University of Medicine and Dentistry at Robert Wood Johnson Medical School, and completed a residency in adult psychiatry and child and adolescent psychiatry at Dartmouth Hitchcock Medical Center. Dr. McLaren's clinical practice focuses on caring for children, adolescents, and adults with autism and neurodevelopmental disabilities. We also have Andrea Caoili joining us. I've tried really hard. I had to text her before.
That was
to get her name
fantastic.
right.
Good work.
She's a licensed clinical social worker with more than 15 years of experience in the field of mental health. She's also the director of research and quality assurance at the Center for START Services and is an adjunct professor in the Department of Social Work at the University of New Hampshire. In work with Center for START Services, Andrea oversees and supports START programs with meeting model fidelity and program certification. In collaboration with Dr. Beasley, she oversees the research and evaluation activities of the entire center. Andrea has experience in practicing and training other clinicians in wellness-based positive interventions for persons with IDD. She's also interested in applied and participatory research in IDD, mental health, and measurement development. And so without further ado, I'll turn the time over to you three. We're looking really forward to what y'all have today. Thank you.
Thank you, Ty, and you did fantastic on my last name. It's not an easy name to pronounce. You guys can see on the screen. It has pretty much every vowel in there, some of them multiple times. So thank you for introducing us. I'm going to go ahead and share my screen. Can you all hear me okay? Jen and Melanie, you can hear me? Okay.
Yeah, we're good.
Good. Okay. All right, so I'm going to sort of kick us off and just talk a little bit about what we're going to be presenting to you and then hand it over to some of my colleagues. The title of our presentation is Integrated Mental Health Treatment Guidelines for Prescribers and Intellectual and Developmental Disabilities. This was a project that was funded by the WITH Foundation. And so thanks to Ty, he introduced us so nicely, but just real quickly, I'm Andrea. We also have Melanie Hecker here, who's a training and research associate at the Center for START Services, and Dr. Jen McLaren, who is our Chief Medical Officer at CSS. I just want to give a quick shout out to other members of our leadership team and our editing team for the guidelines, Dr. Joan Beasley, Susan Click, and Dr. Jarrett Barnhill. They're not here, but their contribution was immeasurable, really. So what we're going to cover today, what we're going to talk about is the development, the way in which we developed guidelines for prescribers, which focus on diagnosis and treatment of persons with intellectual and developmental disabilities and mental health service experiences. The website there is actually a link directly to the best practice guidelines, which are free and completely accessible on the Center for START Services website. You can download it. You can scroll through the different pages. It's all there. It's completely free to everybody. So I just kind of wanted to put that out there for you all. And basically the way our presentation is going to be structured, Jen will talk a little bit about the background, like why in the world we decided to do this to begin with. Melanie and I will focus on methods and results and what we learned and how what we learned influenced the development of our guidelines. And then Melanie and Jen are going to take it from there and really talk to you guys about some of the specifics, like what are some things that we learned worked really well in developing guidelines such as this, and what does this mean for the field as a whole? And then we'll just sort of wrap it up with next steps and what some implications are for current practice and how we plan to move forward. And I think we will have time for questions and comments at the end if we stick to our time. So I am gonna hand this over to Jen.
Thank you, Andrea. And if you want to go to the next slide. So in our practices clinically and across the United States, we have seen and across the research literature that individuals with IDD struggle with mental health issues, right? We all know that. However, there has been this common misconception that sometimes mental health issues are all behavioral issues or they're not there. But study after study after study after study has consistently shown that individuals with IDD actually struggle with elevated rates of comorbid mental health issues compared to adults without IDD. And you can see in this chart the point prevalence rates of mental health issues in individuals with IDD. The 4 studies on the left include individuals with IDD, and the rates show anywhere from a 33% to 46.3% comorbid mental health issues, compared to a national study in the US of adults without IDD have about a 26.2% point prevalence rates of comorbid mental health issues. Next slide. So we know that there are about 331 people in the United States, and 47 million of those people struggle with mental illness. And there's about 7.3 million people in the US with IDD, and 2.5 million of those individuals struggle with comorbid mental health issues in IDD. 2.5 million people. Next slide. So those 2.5 million people really need good psychiatric and medical care. However, what we have consistently heard, and that people consistently say with IDD, is that they have noted a lack of appropriately trained and willing healthcare providers, right? It's a lot of people who are having lack of access to healthcare providers who fully understand their needs in terms of their medical needs, their developmental needs, and their comorbid mental health issues. We know that few healthcare providers receive guidance on caring for individuals with IDD and MH, and that starts as early as in their medical training. There's a lack of didactics, there's a lack of clinical exposure that continues into their residency and their fellowship, where healthcare providers do not feel like they are adequately trained to care for the complex needs of people with IDD and MH. We also know that even those who are trained, really there's like a lack of systematic training. It might be, if they even get any training, one lecture or a little bit of exposure, but not a full training module or full guidelines that they're exposed to. And this lack of training really leads to a treatment bias, one that leads to psychotropic polypharmacy for people with IDD, MH, where they may be treated with 2, 3, 4, 5, 6, I've seen as many as 7 or 8 psychotropic medications to treat individuals, or an overuse of high-risk psychotropic medications like overuse of antipsychotics or overuse of antiepileptics in people who do not have comorbid seizure disorders. And those are medications with a really high risk to benefit ratio if they're not clinically indicated. And what we see then is that there's adverse medication side effects that are not recognized, that individuals with IDD are more vulnerable to side effects from psychotropic medications. And as you add more and more medications, you may actually see side effects that actually come out as behavioral worsening. And when they're not recognized, another medication's added on to treat that, and then another medication's added on, and then you get into the cycle of not clearly understanding what's going on, but escalating polypharmacy, because we have medical providers that don't fully understand the nuanced treatment that individuals with IDD and MH deserve. Next slide. We also know, due to this lack of training, that there's a combination of overutilization of hospitalizations and emergency departments, right? That we are not really stepping back and thinking about a whole treatment approach. We're just responding to crisis after crisis after crisis, and that the most complex individuals who have higher rates of ED hospitalization have chronic health conditions, psychosocial variables, trauma, and adverse medication side effects, and really need a comprehensive plan of care. What we also need to think about are community-based intervention. Dr. Beasley noted in a paper in 2018 that we need systematic training and guidance on the positive and negative influences of psychotropic medications, right? Because there's both positive and negatives, in a comprehensive plan of care, ideally where we're looking at the whole person and the whole system of care. Next slide. So what we were thinking about was guidelines, and we looked at guidelines. Guidelines are out there, but they don't specifically address people with IDD and MH. And they don't take in the input from service users, right? They're not asking the service users, what are you looking for? What do you need? What should prescribers know? And there isn't an emphasis in these previous guidelines on integrated health and mental health, really looking at how to integrate treatments, how to look at the whole person. These guidelines weren't looking at a comprehensive diagnostic and treatment approaches for people with IDD MH, where we wanted the guidelines to address the full developmental and biopsychosocial formulation and treatment process of individuals. Next slide. So the rationale really was that people with IDD and co-occurring mental health needs experience gaps, right? We know that they experience gaps in who's providing their care, where they're receiving their care, what's being asked of them, and what treatments they're receiving. And those gaps in care really lead to ineffective healthcare services. And we need guidelines to address those healthcare gaps so they can receive better healthcare and psychiatric care. The best practice prescribing guidelines in IDD MH are aimed at a holistic, that's important, holistic, integrated, and interdisciplinary treatment approaches where we're looking at the whole person. Multiple disciplines are thinking about the different treatments together that can address the issues that lead to mental health care disparities, including the overuse of polypharmacy, the overuse of high-risk psychotropics, and that those overuses really undermine the primary health of the individual. The third rationale was that treatment recipients and their families were really seen as integral partners to develop effective guidelines and assure prescribers are aware of and understand the impact of the medical and psychosocial factors have on a person's well-being. And we made sure that the voices of service users and their families were included. Next slide. So I'm going to turn it over to Andrea and Melanie.
Thank you, Jen. I really appreciate how you hit a couple core components or core philosophies that our research team had right from the beginning. It's not letting me advance. There we go. We went into this situation thinking we know a little bit. We all collectively, as a community of practitioners, know kind of some nuts and bolts about how to support people in general. But in terms of IDD practice, IDD research, IDD treatment, there's a few things that are missing. And those words that you highlighted were holistic, integrated approach, and the voices of patients and family members. That those were key things that in our lit review, when we really kind of dove into what's already available, we just couldn't consistently find those things. So those philosophies and those perspectives became our touchstone as we developed these guidelines. And I know that that will come across as we continue to talk, but I just wanted to sort of mention that. Our study aims were really threefold. One, we're not wizards. We're not sure. We went into this situation thinking we have a whole lot to learn here. So we really wanted to hold a series of focus groups with stakeholders and use what we learned from these focus groups to inform the development of our guidelines. Our second aim was to actually develop the guidelines, right? To develop these guidelines based on what we learned, and then to seek input and review from physicians across the United States, and ultimately disseminate the guidelines widely across treatment communities. And the third thing we wanted to do is measure the impact of the best practice guidelines on three things: prescriber knowledge, confidence, and attitudes toward the treatment of individuals with IDD and mental health service needs. And the way in which we accomplished those things were through 4 primary methods. As I mentioned, we held a series of diverse stakeholder groups, which were really aimed to identify perceived gaps in prescriber knowledge and to inform the development of the guidelines. And Melanie is going to talk in depth about that in just a second. The second method that we used was we used a collaborative and an interdisciplinary approach to developing the draft guidelines. We use these draft guidelines, or this beta version of the integrated mental health treatment guidelines for prescribers, and we provided that to a number of prescribers across the US who evaluated it. We then took that feedback, made modifications. In some situations, we added entire sections to our guide, and then it was finalized. So we'll talk through each of these things. I'm going to turn it over to Melanie real quick to speak specifically on focus groups.
Certainly. So in order to collect the type of information we needed, we held 6 focus groups across 4 stakeholder groups. And these were a focus group consisting of family members or caregivers of people with IDD-MH, self-advocates who have lived experiences with IDD-MH themselves, medical providers who prescribe prescription medication, and non-prescribing clinicians, sort of a catch-all category for any clinician that does not specifically prescribe medication. Next slide. So our focus groups were semi-structured, meaning that we went in with an idea of the types of questions we were going to ask, but we're overall very flexible in how the focus groups wound up going. So here are our focus group questions. For prescribers, we asked them to describe their experiences in seeing patients with IDD-MH and interacting with prescribers who see patients with IDD-MH. And in terms of people with IDD and their family members, they were also asked how they interact with prescribers. We're asked, what do physicians need to know to best support people with IDD-MH? What things besides a diagnosis or a disability is important for physicians to know about a person before prescribing medication? Because as I will talk about later on, people are multifaceted. We are more than just our disabilities. And recommendations that self-advocates and family members and caregivers can have for prescribers who might want to treat people with IDD-MH. So here are the methods that we used in our focus groups. We started with the initial questioning of issues faced in prescribers' offices described on the previous slide. But once we had received the base answers for those questions, we probed our focus group participants for additional details. And this probing of additional details sometimes led to even new topic areas that we had not considered. Once all of our information was collected, we went through the notes to identify the broad themes that were present in the information we were being given. So here are those themes. The first and maybe one of the most important themes is relationships, communication, openness. And we have some quotes from focus group participants that illustrate what we mean here. We need to reassure one another. This is in your wheelhouse. You do have experience. You just need to like the people you are treating and find some pleasure in your work. So this theme involves putting together a positive relationship between prescriber and patient, making sure that communication between prescriber and patient is clear and easy and detailed, so that no detail or needed aspect is missed. And finally, openness between provider and patient. Patient not being afraid to disclose something about themselves that may be important, and provider not being afraid of saying anything that they feel might hurt or be wrong towards the patient. The second theme that we identified is understanding the person, their environment, and their culture. So this family member quote, find out what the person looks like at their best. What this means is, what does this person look like when they have everything? What does this person look like when all of their needs are being met? And how can we make sure those needs are met? And the second quote from a person with lived experiences, don't just blow me off by coming for 2 seconds and leaving. So to explain this quote, I'm going to use a different quote by Benjamin Franklin. Benjamin Franklin said, the definition of foolishness is doing the same thing over and over and expecting a different result. And this ties into this quote here, because all too often, prescribers will just try medication after medication after medication without considering other factors that may be influencing the person besides their medication. You need to know the person's interests, their fears, their hopes, what they do for school, what they do for work, what their living environment is like, what their cultural factors are like, race, religion, ethnicity, LGBTQA status, other disabilities they may have. It is only by understanding the whole person and everything about the person that the person's needs can truly be met. Importance of an integrated care and wellness approach. I told my provider I had a bad reaction to a med, so they gave me another. It didn't work. I went to the hospital so many times over those weeks. From a self-advocate, look beyond aggression. Sometimes we look for a quick fix and immediate relief from crisis. We need to be detectives and dig below the surface from a prescriber. So this ties into importance of an integrated care and wellness approach. And not only do we need to understand a patient's contextual factors like their life situation or culture, as I explained in the previous slide, we need to understand any other factors besides the medication that may be affecting the patient's outcomes. And as the prescriber said, we need to look beyond what might be obvious, dig deeper, and see what is truly at the root of the patient's issues. And it might be something completely different from what the provider might think. 4, consideration of treatment modifications. Talk directly to the person first and then others in the room. Be patient and give people time to respond. Sometimes they get nervous in the moment, family member. So this ties into the importance of communicating with your patient and making them feel safe. But in terms of consideration of treatment modifications, it also means looking into alternative methods besides the traditional, such as more holistic or naturopathy methods. Or it could be simply talking with the patient instead of trying to prescribe yet another medication. And recommendations from focus group participants regarding the guidelines, we have used case vignettes, flowcharts, tables, etc. So
Melanie, do you just want to give some final thoughts around the value of the focus groups for this project and kind of what your most important takeaways were?
So yes, so the value of these focus groups was knowing all of the ways not only have people with lived experiences and their families struggled with medication prescribers, but all of the extremely valuable ways in which these problems can be addressed, and how the ways that these problems can be addressed can be a lot easier than what people think.
Thank you. I think one thing that came across in the focus groups too, we talk a lot in kind of IDD and mental health. We talk a lot about silos, right? And it's become sort of a buzz phrase, right? And in some ways, an excuse for why things and why services are not integrated. And what was really important about these focus groups is that that this kind of concept of silos to treatment were reinforced, and also strategies and ways in which to break down those silos. And so we used everything that we learned during our focus groups to develop an outline for our guidelines. So the first step following our focus groups was really just to develop an outline. We had prescribers on our research team. We also have, I'm a clinical social worker. We had policy experts. We have people with lived experience. And so we sort of took everything that we learned and developed an outline. We then reviewed this outline with the START Medical Directors Practice Group. The Center for START Services is housed at the Institute on Disability at UNH. We not only support programs with implementing the START model, we also provide nationwide training and education, and we conduct research. And so we used our existing network and our existing relationships and our START community of medical directors and prescribers to review our outline. They gave us feedback and we made some modifications. From there, we developed a beta version of our guidelines. And these guidelines were really, truly interdisciplinary. And we used a participatory approach from start to finish. So every single section of our guidelines had multiple contributors from a variety of disciplines and experiences. In addition to our primary research team and our editing team, these are our other contributors. It's a very diverse group of people from across the country with a variety of backgrounds. And each of these contributors were volunteers, with the exception of people with lived experiences. They were compensated for their participation. And so just as a snapshot, these are the different sections of our guidelines. Jen's going to dive a little bit deeper into certain sections in a little bit, but I wanted to give you a snapshot here. We really felt that it was important, based on what we learned from our focus groups and based on what we know is missing in current guidelines, we needed to lay a foundation. The foundation needed to be laid with positive psychology, positive medicine, and an integrated care approach right from the beginning. So, and we also needed to lay a foundation around the fundamentals of psychopharmacology. We are not here saying that we developed a textbook in psychopharm. We did not develop, a comprehensive, vast textbook that can be used to learn every single thing that you possibly could around prescribing. It's too big of a job to do. What we wanted to do was lay a foundation and then really dive in and address where we see gaps and where our community sees some gaps. So that's what we aim to do with our kind of general fundamentals and positive psychology. We know that there's such a reciprocal relationship between physical health, mental well-being, and positive engagement, right? And if we didn't include that in our guidelines, we'd be doing everybody a disservice. And then we also have an entire section of the guidelines that's focused on the lived experience perspective. There's a section on working with patients and families, considerations for waiting rooms, sensory consideration, and culturally competent prescribing. You'll see a couple asterisks because in 2 places, these are kind of the areas where we had the most feedback and we made the most revision, or we actually added additional content. So this was part of our base section on culturally competent prescribing, was part of our beta version, but we received a lot of feedback around ways to build it out more. So that's what we did. But one thing I'm not sure if you all know, that the DSM actually has like a little hidden gem in it, in the back of the DSM. It's called the Cultural Formulation Interview. If I could see everybody's face, I'd make you raise your hand and give me like a hand count of how many people know that that's there. It's not a lot. It's not a very utilized tool, and it's such a shame. And so there are resources out there that sort of get buried because we're so focused on medication, we're so focused on reducing aggression, and we're so focused on addressing symptoms that we forget that these things are out there. So we didn't want to recreate any of those things. We wanted to shine a light on it. And that's what we did with this guide, is we shined a light on all of these sort of little hidden gems. And we picked out the pieces of that cultural formulation interview and used that and referenced that in our guide. So we're not going to repeat what's already available there. We connect you to resources. A couple of things that really jumped out that we really felt like we needed to make sure were front and center in the development of the guidelines were kind of these concepts of using plain language across the board, just universal plain language. Speaking directly to the patient, not always 100% relying on collateral contacts or informants. There's a lot of reliance in our field on informants, and we do ourselves a disservice when we don't see it as our responsibility to engage the patient in communicating. So that's kind of what we focused on in this lived experience perspective. There's a section on medical assessment and psychiatric assessment. In the psychiatric assessment section, there's an entire list of alternative treatments that go beyond medication that are indicated for persons with intellectual or developmental disabilities, including expressive therapies, interactive behavioral therapy, positive cognitive behavioral therapy, and there's links to the literature where people can find more information about those things. And really kind of the crux, obviously, of our guidelines is this next section, best practices in IDD diagnosis and treatment. This section did not cover every single diagnosis in the DSM. Rather, we elected, with the support of our focus group participants and with the review and feedback from medical practitioners across the country, that these 6 sections or these 6 areas were really the areas that required the most focus. So that's how we selected these sections. And then lastly, our guidelines include a section on prescribing in mental health crises. And that's asterisks, because I'll tell you why in a minute. That wasn't part of the original version. So once we had our beta version, we recruited physicians and prescribers to review it. When I say prescribers, I mean physicians, but also nurse practitioners and physician's assistants. We had a handful of NPs and PAs who also provided review and feedback. And we offered a password protected PDF copy of the guidelines. A total of 43 prescribers reviewed and provided feedback. We were aiming for 100, but there was this little elephant in the room called COVID-19 that made life look a little different for people. So we were really pleased, and that we had almost 50 prescribers agree to review the guidelines. And they completed an online feedback survey and offered some qualitative feedback. Overall, the survey feedback that we received was very positive. The case vignettes were like a huge hit. So in every single section, there's a case vignette that just kind of makes all of the concepts in the guidelines feel much more applicable and generalizable and easy to apply in practice. So that was a major hit. They also really liked our easy to use tables. There were summary sections in each area of the guide, and there were some key takeaways. And so just being able to really summarize things in an easy to use, easy to digest version really was a hit. And we also, as I mentioned, we received a whole bunch of qualitative responses. We actually received 43 qualitative responses from 43 reviewers. In terms of survey development and data analysis, guys, that gets me excited because it is inevitable that people will kind of flick it. When you fill out this evaluation for this training, right? You're going to click through and say, you know, Andrea talks too much. Yes, blah, blah, blah. And you're going to click all of these things, like all of these kind of Likert scale questions. And then you'll get to the, what other feedback do you have? Not every single one of you are going to fill that out. And that is completely okay, because you're not always going to have that feedback, right? That's sort of expected. And that is completely acceptable. In this situation, however, every single one of these reviewers offered a statement of feedback. And that was really amazing to me as an evaluator and as I was doing that analysis. So what we did is we coded each of these pieces of feedback and we put them into 3 categories. We put it into kind of general feedback. These are some things that we want to consider for the guide overall. Here's some specific recommendations, treatment recommendations, diagnosis recommendations that perhaps we missed. For example, there was a situation where a physician mentioned that now that we know that physicians' offices have the capacity and have the ability to have people wait in their cars for their appointments, because we learned that during COVID, maybe that's something that might be beneficial to continue. We're not sure. So that was like, those are kind of some more focused recommendations. And then we did have some thoughts that were more kind of opinion-based, that were not really 100% backed by research. So we sort of put those in our back pocket and remembered those and tried to make sure that we had ample resources for folks if they were looking for them. And as I mentioned, there were 2 primary areas of the guidelines that required either revision or addition. One was culturally competent prescribing. And the second was prescribing in mental health crises, which is really ironic because START is a crisis service for persons with IDD and mental health service experiences, but we did not explicitly include initially a section on mental health crisis. And so that's kind of what happens when you're developing, that one thing I've learned is that as you're developing these guidelines, as you're developing resources, you have these little light bulbs, and the light bulbs may shoot on at different phases in the process. So we made sure to include that in the final version of the guide. I guess the only other thing that I'll mention or reiterate is that the guidelines are available free of cost on the Center for START Services website. And it was an incredibly rewarding experience to learn from those people right from the beginning that were sitting in the patient's chair or were in the office, in the prescriber's office as a family member. It was such an honor to have them participate in this process and for those themes to kind of carry throughout the development of the guidelines.
So I'm going to cover some of the main issues that were raised in the focus groups across all 4 group types. So the first is patient-provider communication, which can cover a few areas, such as communicating in a way that a patient can understand, potential miscommunications, communicating directly to the patient instead of an interpreter or caregiver who may be with them, waiting room considerations, which I will talk about a little bit later on. There is a lot related to waiting rooms that we never even considered until a certain testimony in the family caregiver focus group. Multifaceted approaches treating the whole person instead of just part of them, using multiple methods to help patients, not just medications. Next slide. Accommodations in office, such as, for instance, the waiting in your car accommodation that Andrea discussed earlier, or lowering television or music noise if the patient requires. Disability etiquette. So disability etiquette is things like not touching a person's mobility aid unless you have permission to. Again, speaking to the patient instead of around them, not distracting a patient's service animal, not interrupting somebody who has issues with stuttering. And finally, sensory considerations. Sensory issues are a hallmark of many developmental and intellectual disabilities, and there can be a lot in a provider's office that can trigger somebody's sensory issues, whether it's something visual, like flickering fluorescent lights or overstimulation from having too many decorations on the walls, to textile sensory considerations, like not being able to stand the touch of something like chalk or clay or cotton, hospital gowns being too scratchy or tight, and of course, considerations related to smell or hearing, like high pitch, low pitch, repetitive noises, or the smell of ammonia or alcohol or garbage. Next slide. So I'm going to talk specifically about the waiting room consideration section, because as I mentioned earlier, this was a section that we did not even intend to include until one particular family member told us some pretty disturbing stories about the younger brother that he was a caregiver for. And listen to this quote: "Waiting room incidents are a common problem for us. Nurses say, 'Who is this kid?' and it just escalates from there." What this family member was talking about were waiting room staff who had a tendency to chastise his brother right there in the waiting room, which made his brother, who was already nervous about being in a doctor's office waiting room, even more nervous. And this is when we knew that we needed to include this section. So this section included both the physical design of the waiting room, because of the sensory considerations that I described earlier, but also training your waiting room staff to know the most basic information about intellectual disabilities, developmental disabilities, and mental health challenges, to come from a place of understanding of how a patient may act if they seem to be acting strange or in a way that's perceived as misbehavior, and to never, ever chastise a patient in the waiting room. Next slide.
Thank you, Melanie. So you may be asking yourself, well, how does this guideline or these guidelines contribute to the field? Well, first off, it's a first guideline of this type that is free and easily accessible to all prescribers throughout the country or even internationally. And it really, we hope it helps address some of the disparity in how prescribers are trained, their background knowledge, and how they practice. We hope that it reduces the over-reliance on psychotropic medications and reduces the polypharmacy and the use of high-risk medications. We also hope that it reduces the over-reliance on the emergency department and hospitalizations. We also want to recognize that the guidelines really emphasize how to engage patients, how to make a thoughtful diagnosis and take a step back, how to think about multifaceted treatment approaches instead of just the singular going to changing a new medication, and how to think about different approaches, and really emphasizing again that interdisciplinary, inclusive, and culturally competent approaches. It's important to recognize that the guidelines work really, each section of the guidelines are very short. So a prescriber can do a very quick read of a certain section before they go see an individual and their caregivers. They can reference the tables when they're in the room with an individual who's struggling with a specific issue, like if they were struggling with depression, and we'll go through some of this, they can have the guideline and table out and think about, okay, how do I approach this? So we hope it is an easy to use guide to help provide better care. Next slide. So I think Andrea really addresses, this is actually a screenshot, and I'm going to show you several different screenshots from the guidelines so you can see what do they actually even look like. This is the first section of the table of contents where it looks the different sections on lived experiences that Andrea went through. The second section on psychiatric assessment considerations in the different chapters. Next slide. And then the section on best practices in MH diagnosis and treatment, and the different specific diagnoses that we went over. And then the last section on prescribing and mental health crises. So you can see, you could quickly go through the table of contents, find where you need to be for specific individuals, and go to that chapter to help guide you. Next slide. So I'm going to now take a dive into two different sections of the guideline, and so we can look at what they look like and how they're structured, because they are all structured very similarly. And that was on purpose, so if you used one section, you were able to quickly reference then another section. This is the Depressive Disorders Guideline, and this is not meant for you to read right now, so you can take a look at it and then point out some highlights in the Depressive Disorders section. So the first section of the guidelines will typically give you an overview of the different diagnoses. So for depressive disorders, it talks about specifically the lifetime prevalence is pretty high, it's 37%. And then it talks about common antecedents for individuals with IDD for depression. It could be personal loss, such as caregiver, friends, staff, isolation, marginalization, meaninglessness, lack of autonomy, trauma, bullying, victimization, or other adverse experiences, cueing the prescriber to ask the individual and ideally their caregiver about these experiences. And then there's a section on assessment. And it talks about some of the core features and some of the different diagnoses that may be made. And then the next section focuses on some treatment approaches. And you'll see that it'll say what to do for if somebody struggles with a more moderate to severe presentation of depression versus if they have a more mild presentation of depression. And it talks about medications and or therapy treatments. Next slide. And then the sections will go into further detail for prescribers regarding medications. So this section specifically points at several different psychotropic medications and some side effects to consider when targeting depression for individuals with IDD. It then talks about medications we may not consider using because of a higher risk-benefit ratio. And then it also talks about when should you expect improvement and how to monitor individuals in terms of treatment for depression. And it stresses utilizing a stepwise treatment approach and using the lowest effective dose. Next slide. This is my favorite part of the guidelines, is the different tables in the guidelines. As a psychiatric prescriber and a clinician, sometimes you can have a busy day, and just referencing a page and being able to reference it if it's something that you're not familiar with can be very, very helpful. So this table points out the key components in assessing depression in individuals with IDD. So the first section of this talks about really getting a comprehensive history with collateral information, including behavioral observations from caregivers, residential staff, day staffs. All too commonly, we see that people are not getting a whole picture of the individual. And having a good understanding, like was stressed before, of the individual's baseline functioning and what that change looked like. What does the individual look like when they're doing well? It gives you specific questions to ask. When did they last appear that way? And the next section points out symptoms of depression, which may include very specific symptoms. It gives you a timeline and severity in terms of some questions to further ask. So it's very, very user-friendly, literally giving prescribers like, what should I even ask the individual and their caregiver? It also tells you to assess for other symptoms, other diagnoses like mania or hypomania, to rule out bipolar, look for comorbid substance abuse issues, look for psychosocial stressors and abuse, obtain a family history. All important aspects to remind prescribers of things to ask. It also gives the prescribers a guide of what to look for on physical examination. Important things to review on the individual's medication list, and importantly, asking about complementary or alternative medications, asking about specific medications that can help, that can actually contribute to symptoms of a depression and make people feel more depressed. It gives prescribers specific things to look at when they're interacting with the individual on their examination. And it also guides prescribers on what labs should they even order when they're assessing individuals with IDD who may be struggling with depression. Next slide. There's also some information about what if my patient or the individual I'm caring for isn't responding to the treatments? What else should I do? So it talks about treatment resistance to the previous treatments tried. Like if they tried a certain medication and things weren't improving, what else should they try? Next slide. Also, many of the guidelines include different figures. So it's again a quick look at what is the consensus regarding prescribing for individuals with IDD, MH regarding treatment of depression. And you could see this has different jargon in it, but it talks about initially, if somebody's struggling with depression, you may want to try an SSRI. If there's no improvement, what do you do? You would substitute a different SSRI. Then what do you do? And it takes you through the medication algorithm, but also the guidelines talk about the psychotherapeutic treatments and other interventions as well. Next slide. So again, this is the star of the guidelines, the case vignette. And I'm going to point out some important aspects of the vignette, because the vignettes really, I think, stress the interdisciplinary, holistic, culturally competent treatment approaches that we were really trying to teach and guide prescribers to utilize. So this individual in the vignette talks about an individual who has mild ID. It talks about when they're doing well, what the individual looks like, how long the caregiver has known the individual and lived with them, and what the caregiver's concerns are. And then it talks about at interview, what the individual reports in terms of how they're feeling when they're depressed. It talks about the individual's stressors in their life and how that's made them feel. It talks about the individual's family history. It also talks about getting rating scales from the individual regarding, and their caregiver regarding how they actually feel. And then importantly here, in the third paragraph, the vignette talks about what to do to help somebody with IDD and depression make gains. So there's things besides medications, right, that we can do. So in this vignette, the prescriber encouraged the caregiver to purposely schedule enjoyable and meaningful activities to engage Mr. F, who was the individual struggling with depression. The caregiver was encouraged to validate feelings of loss that the individual was experiencing, given losses in terms of individuals who had previously cared for him. The individual was started on an SSRI to treat symptoms of depression. The individual was referred for modified CBT, and several weeks later got into therapy that was targeted at their neuropsychological cognitive strengths. And in this situation, with the multifaceted treatment approach, Mr. F was no longer struggling with depression by the end of this vignette. Next slide. So that's really what a specific chapter in the guideline looks at in terms of the different mental health diagnoses. And I'm going to next go into how prescribing in mental health crises, the outline of this chapter. And this was a chapter that Dr. Barnhill, the editor of the guidelines, also contributed a lot to, and I appreciate his contributions to this. So in this guideline, we outline like what it even is a mental health crisis and who is vulnerable to those. And we talk about what are some possible biopsychosocial risk factors. And then we talk about how and for whom do we even evaluate, and where is the best place to evaluate, right? We talk about the pros and cons of evaluating somebody in the emergency department versus evaluating them in the community, and how you have to weigh the benefits and the risks of each environment in terms of the evaluation. Next chapter. Next slide. In the assessment of prescribing in mental health crises, we talk about what an assessment even begins with, right? We want to obtain enough history really to determine what the individual's previous functional baseline looks like, and a search for what are the things that are predisposing and precipitating the crisis. And there's really 3 useful timelines that we hope prescribers utilize: how to track the description of the emotional states or evolving signs and symptoms, the time of appearance, escalation, frequency, and the level of intensity. The next, number 2, is to develop a biopsychosocial and ecological timelines and maps of the current life stressors. That's so important for the individuals that we care for. 3 is to develop a timeline of interventions during this crisis in previous episodes. We want to know what interventions have been tried and if they made things better or worse, and how they've impacted the individual and their caregivers. And this approach is really helpful, right? We didn't want to recreate things, but we pointed out is really helpful when utilizing the DMID2. So we give out the shout out to the DMID2, and hopefully this will cue prescribers, if they don't know what it is, to look it up, get one, have it in their office to utilize. And then we give a table that you're going to see in the next slide. So we actually, in this guideline as well, we give a table that prescribers can utilize when they are in an ED, in the community, in their office, and seeing somebody who is in a crisis. And what we always hope prescribers do is they start out utilizing, there's this mnemonic that was developed by another guideline that we really liked and we cited here, called Head to Toes, that we look for medical and neurologic disorders that could be contributing to the individual struggling and being in a crisis. So, right, this gives the prescribers, like, what do I even look for in terms of pain, right? You look at a headache, you look for epilepsy, aspiration pneumonia, or dysphagia. You look for medication side effects, what drugs are being utilized. You look at the individual's teeth and in their mouth to see if they're having any pain, infections, abscess, impacted teeth. You also look at ocular and ear, nose, and throat issues, right? You like earaches, hearing issues, sinusitis, vision problems. Are they struggling with sleep apnea? And you look at their tummy. Are they having GI distress or reflux or constipation or obstruction, or even a more serious issue like a volvulus? And then you look for at their bones in terms of osteoporosis, or their skin and pressure sores. You look for etiological causes of IDD. Is there a genetic syndrome that the individual has that has certain medical issues that go along with it? Or is there a new onset illness like hypothyroidism, type 2 diabetes? And you always screen for abuse when somebody's in crisis. And then it cues the prescriber to look for other stressors, right? Psychosocial stressors, substance abuse, comorbid psychiatric disorders. It reminds prescribers in a crisis, we still want to conduct a full and comprehensive physical examination. And then you always do in a crisis a full mental status examination. It gives the prescribers what specific labs should I order when an individual with IDD and MH is in crisis. It gives the prescriber some common labs and what imaging in terms of should you do abdominal imaging, should you do an MRI? It gives you a guide for that as well. Next slide. And then there's a section, because this is where we see that individuals can get started sometimes newly in ED or in the hospital when they're in crisis on psychotropic medication. So it talks about, importantly, the use of psychotropic medications when somebody's in crisis and how this really is a balancing act, especially when somebody's acutely in crisis. We want to keep the individual safe. We want to keep people in their environment safe, but we also don't want to over sedate the individual so they can't participate in their own medical care. So we have a table that outlines what are some non-pharmacologic, non-medication strategies to utilize in crisis. Like, what can I do in that moment to de-escalate the individual? So it talks about utilizing verbal strategies, finding out from other people who know that individual well, what is comforting, soothing, and enjoyable. And this is so, I think, obvious to all of us, but sometimes when people are under stress, they forget the obvious, like, right, how should we be asking the caregiver, what helps de-escalate the individual when they're at home, when they're in the emergency department? Can we recreate that environment? Utilizing a quiet room and minimizing things that can be really distressing, right? Like loud noises, fluorescent lights, ensuring that we have the individual in a safe environment and having other individuals participate in the history giving, having consistent staff. So if they're in an ED setting, instead of having lots of different staff, having as much consistency as possible and minimizing other contacts who are not essential to their care. And making sure that we explain and demonstrate when possible what's about to be done in terms of a physical exam or if any medical procedures need to be done. Importantly, minimizing any restraints or injections as much as needed. And then we cue people back to, there's a really nice chapter on sensory recommendations for medication prescribers. Next slide. And then lastly, we end this chapter with when do we prescribe? And we talk further about that. In what situations do we prescribe psychotropic medications? Who should get psychotropic medications? And then we always give some important references to cue readers back if they want more information or a deeper dive into this specific topic area. Next slide. I'm going to let Andrea take over here. Oh,
I couldn't find my mouse. It advanced a whole lot. Thank you, Jen and Melanie, for sort of talking through kind of the key takeaways and also showing some of some sections of the guidelines. It's interesting what you said, Jen, about like the list at the end of the mental health crisis section, that a lot of this is common sense, right? And really, that's what guidelines are, guys. Guidelines are it's a culmination of kind of pulling together all the best practices and kind of common practices that we should use every single day. And the purpose of having these additional resources is so that when a prescriber does want some additional information, they know where to go. So I really appreciate you kind of showing that, and then also demonstrating how each section sort of builds on one another, and how if you need some information, if you're working with somebody in a crisis, it is probably likely that there's the possibility of some level of sensory related issues in that moment. And so there's a section on that where prescribers can go back to. So in general, we've kind of hit a lot of this, but just in general and in summary, the strengths of this study were really the fact that we used participatory research strategies from start to finish. It's not just a best practice. It's not just the right thing to do. It increases the depth and meaning behind everything that we developed. And so these guidelines would not be as effective or as comprehensive as they are without the participation of patients and family members. And the focus groups were really the primary vehicle for receiving that information. Another strength was that we had stakeholder input from start to finish in terms of prescriber feedback. These are physicians, those that provided feedback are physicians that are currently in the field. They recognize the challenges. They know what works for them. And so having their feedback was really invaluable. And lastly, as I mentioned, feedback from people with lived experience. The challenges, the primary challenge of this study, and really all studies over the last 12 to 18 months, was just the change in practices around COVID. We had some ideas on how we would engage people in focus groups, and how we would seek participation from prescribers in reviewing the guidelines. Some of them included, having like open meetings at our training institute or other training venues or events that we have at the Center for Start Services. But that all turned virtual. And a lot of people were handling a lot of stuff. And so recruitment was challenging, and getting that feedback was challenging, but we were really lucky to have a network that is engaged, and we were still able to get up to almost 50 prescribers to review the guidelines. Melanie or Jen, any other strengths or challenges that you can think of? I'm putting you on the spot. I didn't say I was going to ask you to do this, but Melanie loves it when I put her on the spot.
Okay, you got me. I would say a big strength is the flexibility that we utilized in creating and writing this guide. How we were perfectly willing to change paths or add paths if we needed to, based on our focus group feedback.
Thank you.
I think another strength was that each section of the guideline was written by different people, and a lot of them brought different perspectives. And it really was a group of experts in the field across the country who have extensive experience in caring for people with IDD, MH, and it really was an interdisciplinary group of child psychiatrists, adult psychiatrists, psychologists, individuals, their families. So it was, I think, a really holistic process too. And it was fun, I think, to be a part of this project.
It was very fun. Yeah. So we had OTs, rec therapists, primary care physicians. It very much was an integrated approach. So next steps. It is impossible to know everything that needs to be included in guidelines like these. So these guidelines will continue to be evaluated, reviewed, and modified every 2 years. As new research comes out, as new evidence becomes available, it will be incorporated into the guidelines. The guidelines were developed with an adult mental health care idea in mind. And there really is a need for additional resources for physicians, prescribers who focus on children and adolescents. So while some of the content is applicable across all ages, not all of it is. Diagnostic and treatment-specific recommendations for children and adolescents would certainly be beneficial. So that's something we're going to continue to explore. The other thing that we know is that written guidelines only go so far. They do not take the place of professional development, of training, of experience, of sort of this experiential learning that comes with working with human beings. And so there is a need for more professional development and training for medical students, for residents, really across the country. In research, it is medical students and residents often report in research that they want more IDD focused curriculum. Disability advocates have long advocated for IDD focused curriculum and for these types of enhancements. Medical students and residents want more opportunity to interface with patients with IDD and mental health service needs. And so it is really our role as an interdisciplinary network to develop those resources and to provide these professional development opportunities for these disciplines. So that is definitely a next step and an implication, something that we need to continue to do. And so that is all that we have here in terms of a structured presentation. So I think, Ty, what I'm going to do is I'm going to stop sharing my screen so I can see everyone's faces. Whoops, I didn't stop sharing my screen. There we go. Now I did. And just give an opportunity either for my co-presenters to share any final thoughts, and we can field a few questions or comments if there are some.
Yeah, I'll jump in just to try to get to some of these questions. There was around dissemination, and I think it's an important question for all we do, and I'm sure y'all have thought through strategies, and part of the strategy is coming to events like this, but I think a lot of the theme of questions I was seeing is, well, how do we disseminate this more effectively to providers? It's in my rural area, for instance, I've just sent it to all the providers I work with and say, hey, this is helpful for the clients we work with. Please read this. And then I text them over and over again until I can tell they've read it. But I'm curious, is there a strategy from y'all's lens on how you're doing that?
Yeah, nagging is a really good one. I like that. I like that strategy a lot. You know, I think the best way that resources spread is through word of mouth. And so, you know, I think that the way in which it's being disseminated is really helpful. And also, you know, we sent it out to our entire mailing list at the Center for START Services. That's over 4,500 people across multiple disciplines. And so we hope then that it becomes integrated into the work that our START teams are doing across the country, and that resource is shared. It's been available. The guidelines have been available on our website for the last 3 months. It is the most downloaded document on our website of all time. So it's getting out there. There's still more opportunities, and certainly forums like this are really helpful. I think also, you know, as we develop new resources and we integrate new information into our guidelines, we're going to have to continue to push, because the field of mental health we're all ever learning. We're lifelong learners here. And so we're never going to know everything that we need to. And so this kind of constant review is really important in terms of dissemination, knowledge translation, and a document being something that is really helpful. It can't be a one and done. And I think that's our primary kind of way of thinking about dissemination in general at the Center for START Services, that once we develop something, it really is just the beginning. And I think that's our perspective here, that this initial guide is just the beginning, a jumping off point for sharing information that we need to.
And I think I agree with that. I think the START Medical Directors Practice Group, right, that's a group of START Medical Directors across the country. They have shared it by word of mouth with other prescribers and that they practice with. And then we also shared it with organizations. So we shared it with the American Academy of Child Adolescent Psychiatry, their subcommittee, IDD subcommittee, who really liked this, and then shared it with other people. So I think it's slowly getting spread, and I think encouraging practitioners to use it. I think once, I can't imagine practitioners are going to just sit down and read it, right? Because they're busy, right? So I like that they could use it as part of their work day. and quickly read it and reference it. It'd be a lot to ask somebody, and maybe not that interesting, to just sit and read 30 pages of it one night, right? So I think it'll be digested by prescribers in pieces, which is, I think, how it's meant to be as a guideline.
I'm kind of scrolling through questions. There were a decent amount of questions just around dissemination and getting access to this. What I'll do real quick is I will put the link directly in the chat. So you all, and we have our slides that we can send along too. We just didn't do that because we didn't get them done in time for Ty to get them out to you guys.
Right, and the guides are available on the Center for Start Services website at any time.
This is my reading face.
Well, while Andrea is focusing on that, there's a question that I'll address. I am a geriatric social worker and work with an adult client caregiver who is over 50 years of age and has been treated for ADHD and anxiety. Their psychiatric NP reportedly shared that, unfortunately, meds prescribed to manage ADHD, such as distractibility, difficulty concentrating, challenges with following through on tasks. Unfortunately, the meds that are currently available to intervene to help with said symptoms becomes significantly less effective as people age. What are your thoughts on this topic? And I would say that my thoughts on this topic, but Andrea and Jen can jump in on this as well, is that as we've been talking about through this whole time, medication is not always the answer. And that there are tools to address ADHD and all other sorts of types of challenges without the use of medication. So, for instance, helping to work with somebody to train to how to structure their day, giving them strategies like something that we in the autistic community call STIM toys, where you hold some kind of toy in your hand to help you concentrate better, which, even though you can't see it, I've been doing throughout this whole presentation. And if you look in the guide, you can find even more methods to help address these kinds of challenges besides medication.
And in terms of, ADHD, so typically the natural course of ADHD is we see a natural decrease in hyperactivity symptoms, but a persistence in inattentive symptoms throughout somebody's lifespan. Do medications become less effective? There's not really good studies showing that they become less effective over time. Life certainly becomes more complex, right? As an adult, as compared to a child, you're expected to multitask much, much more and have many things that you're doing. But also, sometimes as people age, in general, they can struggle with some further cognitive dysfunction. So I don't necessarily think it's as easy as medications become less effective over time.
I think the other thing I'll add is that it's hard to make assumptions as a clinician without having met the person. And so I can sort of see these perspectives that Jen and Melanie share. And also I think what I've learned in my work as a clinical social worker, and also in kind of what we heard from participants in this project, is that the way in which people react to their environment, their genetics, their psychosocial experiences, and all of these things really impact the way in which they may respond to certain situations, certain medications, all of these things. So I guess I would sort of what I'm sort of drawn to, Jen, is like, what sort of questions would we have in terms of assessment? What is some additional information that we would want to know in order to make an informed decision about what medication, what the next steps in terms of medication might be, you know?
Yeah. So I think that's a really, you're right. You take a step back and you would want to ask about like, what is an individual's baseline? And when were they doing well in terms of their ADHD symptoms? When did that change? How did that change over time? What else has been going on in their life? Particularly what other stressors or tasks have been added? And have other medication changes happened? Have other medical issues contributed to any of the cognitive difficulties? So you want to sort of ask a lot more than just, my ADHD is not well managed. And, I think just sitting with the caregiver, because it's the caregiver who's struggling, and also understanding, we know that mental health issues can, like anxiety or depression, can affect somebody's cognitive strengths, right? Like it can make your cognitive strengths weaker in terms of attention and staying on task and organizing. And how has the individuals or the caregivers, how has a caregiver's anxiety changed over time with all those questions in terms of doing well? Has it gotten worse? But I also think it's important to think about making sure that that caregiver's in their own treatment and getting the supports that they need.
It's a good point, and I appreciate how you connected, the possibility of physical issues and also just, getting older. We do know that, there's a number of medical issues that could impact a person's ability to be attentive. We also know that depression, for example, could increase a person's difficulty in attention and focus. So all of those things would certainly and can certainly be considered. And that's why a biopsychosocial approach is really imperative, really right from the beginning, right at the point of assessment.
Well, plus growing up never ends. Our brains are always constantly changing as we age, even after we hit 18 or 21. And some of the brain changes that may come from transitioning into middle or older adulthood can affect the changes in things like attention or multitasking. And I also should mention that middle adulthood is probably the least studied stage of development. Actually, it is the least studied stage of development. So a lot of the effects that the transition to middle adulthood has on people is not really all that well known.
And that's like the sandwiching age, right? Where when somebody's in their 50s, they're caring for sometimes their parents and their children. So it can be a very stressful like period for them.
So I'm going to jump in just so we can try to get everyone off to our last session of the day on universal design. But I did want to just briefly say thank you to the three of you. This has really been a very useful product in my little rural community where it's really actually helped us already start to improve lives. So I was really excited to hear y'all's perspective and really appreciate each of you coming and joining us, and hope y'all in attendance found it useful and enjoy the next session. And I'm sure we'll be talking again in the future. Thanks again so much, everyone.
Thank you.
all.